the calendar on that.
Well, me and Tanner,
What's
because
What'd you say?
she's wanting to quit my job because right now she's making more money.
Yeah, send me everything and I'll start putting it in a special folder just for Okay, alright, we're gonna go ahead and get started. We will finish early, so let's get it over with and then y'all can go. Okay, so hemolytic disease of the newborn and fetus. I wanted to say fetus and newborn because that's how the little demonstrative. I didn't make it. Maybe I can fix it. I don't like it. So the other name for it is erythroblastosis fetalis. And that's when the fetal or newborn red cells are destroyed by the mama's IgG antibody. So the fetal cells that are in the baby are being attacked by the mom's antibody that she made that crossed the placenta and attached to those baby's red blood cells. So the maternal antibodies, which are the only ones that cross the placenta, is IgG. They sensitize the fetal red cells and destroy or shorten their survival. So it may occur when fetal cells escape into the maternal circulation as a result of feto-maternal hemorrhage, which is the same thing as the mama-baby blood exchange. That's what that means. It can happen during delivery or before. During an amniocentesis, does everybody know what that is? Where they go in with the big long needle into the fetal sac.
That seems painful.
Yeah.
I bet it hurts. They don't do that as much as they used to because we're gonna talk about the new ways they can measure for fetal anemia. If there's an abortion, spontaneous abortion, whatever reason, chordocentesis, so that's where they can go in with a needle into the actual umbilical cord. I remember what it's called. I don't know why, I can't remember. Ectopic pregnancy, so one of my friends the other day, for real, had a tubal after her last baby, like a tubal ligation, to get her tubes tied, and got pregnant, and it couldn't, because the tube was, I guess they just like cut them all and like burn them or something. And so it made it to the tube, but it couldn't go nowhere else, and it ruptured, and she had to have emergency surgery. I know, so that is still something that can happen if you get your tubes tied. It's not common, but it was so sad. All this stuff can happen. Or if you have abdominal trauma, so if they have a car wreck, or I worked with somebody that was pregnant that fell getting out of her car at the gas station because you lose your balance when you're pregnant because your body's like lopsided. So she fell down and she had to go to the emergency room because she fell down getting out of her car at the gas station. So for whatever reason, that the fetal bleed thing can happen. So fetal red cell antigens that the mother does not have stimulates the mother to make an antibody. So she doesn't have the antigen, the baby gets it from the daddy, and then she gets exposed to it through the fetal-maternal hemorrhage. The antibodies bind to the fetal antigens and cause red blood cell destruction in the fetal liver and the spleen. So the antibodies, the mama's antibodies, cross the placenta, attach to the baby's red cells, and the baby's liver and spleen recognizes those cells and starts destroying them. So it can happen before birth and after birth. If it happens while the baby's still in utero, the indirect bilirubin that's created from the hemolysis is conjugated by the mama's liver. So that can keep it from being so bad, like the baby doesn't get kernicterus in utero because the mama's liver takes care of the bilirubin. As red blood cell destruction continues, fetal erythropoiesis increases. So it starts their bone marrow, or wherever the cells are being made at the time. It starts pushing out early red blood cells, so the ones that still have a nucleus, really early ones. It's trying to make up for the anemia. And so that's where the name erythroblastosis fetalis comes from. So that's like fetal, and this is erythroblast. So edema, this is the worst part that can happen. So edema occurs in the peritoneal and pleural cavities which causes hydrops fatalis, and then cardiac failure can happen. And so this is what happens if it's untreated. And so the cardiac failure happens due to the uncompensated anemia. And you don't have to know that, but it helps me remember it if I understand what's happening. Like, why did this happen? Like, what happened to their heart? I guess it just doesn't, they just don't get enough blood. After birth, the baby's liver is not mature enough to conjugate the bilirubin. The unconjugated bilirubin binds to albumin and then to the tissues. So that's when the kernicterus happens. When the bilirubin deposits in the brain and causes the tissue damage. And so that's what happens if the bilirubin binds to their brain. So it can cross the blood-brain barrier. So 3 important factors must occur. The red blood cell antibody must be IgG. Only IgG crosses the placenta. The fetus must have an antigen that the mother lacks, and so they get it from the father. And the antigen must be well developed at birth. Some of them are not, and so they're not a problem with HDFN. So the 3 types is the RH kind, which doesn't happen as much as it used to, but the book, I never really saw a real case of it, but the book says it still happens. ABO incompatibility, which is usually mild. They usually don't need any therapy. If they need any therapy, like the RH kind used to have exchange transfusions, it can be severe. The ABO kind is usually mild. So you see the babies that are being put under the bilirubin light, that's usually all the treatment they need, if they need any. And then there's some other antibodies that can cause it. What's the main one you would think of? An IgG antibody. Kale, because kale is the second most immunogenic after D, right? And kale antigens are well developed at birth. So the only ones that you need to know for the test, the only ones that affects the firstborn baby is this one. And since it's mild, we really are not that worried about it. So at least it's not this one, and we can do something about that one. And this one's mild, so it doesn't cause any severe problems. So you need to know that for the test. ABO is the only kind that can affect the firstborn. So RH kind, which we're just talking about D, is the most severe. The D negative woman is sensitized in the first pregnancy, but that first pregnancy almost never has problems. So she may not even know she had an anti-D that she made from the first pregnancy. Her second pregnancy with the D positive baby, that's when the mama's antibody attacks the baby. So subsequent pregnancies are affected. They have a positive DAT, so the DAT, remember, it's looking for cells that are coded with an antibody. And so in this case, the baby cells would be coded with anti-D antibody, and that would give a positive DAT. And so jaundice and anemia may occur. Exchange transfusions may be necessary, but we have RhoGAM now that can, the book said, like maybe 0.1% of people can still get an antibody if they're treated with RhoGAM. So it doesn't happen as much as it used to. So remember, an exchange transfusion is where they exchange the whole blood volume. And so they take the baby's blood volume off, the plasma, the blood, everything, and replace it with fresh blood to get the baby's bilirubin down and to correct the anemia. And so, when I was reading about it in the book, so HDFN caused by anti-D still occurs in about 6.7 out of 1,000 live births. So I think that's a lot. I wouldn't have thought it was that high. And so they say that that number reflects the failure to administer RhoGAM. So I guess if the doctor forgot. Inadequate prenatal care. So if you come in and you don't have any prenatal care and you're coming to have a baby, they usually give you a drug test, because in these days you can go to the doctor for free if you're pregnant. And it can happen if the mama gets sensitized to the anti-D, or sensitized to the D antigen before the 28-week mark where they give the first dose. But 6.7, that's a pretty big number. So ABO HDFN, this is the most common type. It's usually a group O mama that has a group A or B baby. And so what antibodies do group O patients make that nobody else makes, the other blood types make? Anti-A, B. So they make anti-A and anti-B, and they make a separate antibody, which is the anti-A, B. And they say that's the one that really causes it. So O mamas, every O mama that doesn't deliver an O baby, or that delivers a RH positive baby, they get a cord blood workup. We don't do cord blood workups on every single baby because sometimes there's no reason to do it. If the mama's antibody screen is negative, and if she's an A or a B, she doesn't need one. Because so it's just a waste of time. So we do cord blood workups. O moms that have A or B babies. Or if they are RH negative and still O and have an RH positive baby. And so in this case, if they were O negative and they had an O positive baby, we're just looking to see if they need RhoGAM, and if they do need RhoGAM, do they need more than one vial, which is part of the RhoGAM workup. So when you get to the lab and they're not doing cord bloods on every single baby, this is why. Yeah, so if the mama is an O and she delivers an A or B baby, or if she's an O and RH negative and has an RH positive baby, that's when the O mamas would still get a RhoGAM workup. And so that's not something you're probably gonna have to think about. The nurses in the nursery know the mama's blood type when she gets there. And once we give them the baby's blood type, or if the mama is the right type to get a RhoGAM workup, then they'll order it for you.
What's the earliest that you can get the baby's blood type?
Without like the invasive
Delivery.
sure.
Delivery. Okay, so they're saying that it's mild because the A and B substances in the tissues may neutralize the antibodies, or the fetal or infant red cells may be poor developed, so the antigens may be poor developed, and the antigen sites may be reduced. So that's why they think that this is mild, the ABO is mild. And there can be some jaundice, and if there is, then they just put them under the little bilirubin light, let them get a suntan. And that usually fixes it. So any IgG antibody can cause HDFN. Big C and little c and KEL are the main ones. I would say KEL is probably more common. The other antibodies are less common. and I've never seen this done before, but they say agglutination with the terminal cells and the mama serum will give a clue to a low frequency antigen. So if they were doing like, I guess that you would consider that a family study. But with the molecular stuff now, they don't, I don't know if they still do. So prenatal testing, so the testing that she has done before she delivers, serves two purposes: to identify D negative women that need Rodiam, and to identify women with antibodies capable of causing HDFN. So here we're looking to see, does she need, you'll see it abbreviated RHIG. So does she need Rodiam? Is her antibody screening positive? And here you're just looking for IgG antibodies.
Give me just a.
So this chart shows the testing that they get at their initial visit, follow-up visits, if she has a positive antibody screen, and the labs that they do at 28 weeks, if some of this stuff is positive. You can go back and look at this chart. Antibody titration, so if she does have an IgG antibody, you can titer it out. Titration helps determine whether other procedures need to be performed. Like, does she need, you don't want to do an amniocentesis for no reason. And so if her antibody titer is going up, and so you know that her antibody strength is going up, then you would want to do more testing. Otherwise, you wouldn't want to do anything invasive for no reason. And so the other procedures include this color Doppler ultrasonography, and you don't have to write it down. And so the development of this has really cut down on the numbers of amniocentesis that people have to get. And there's some other stuff, but all these tests are just looking for fetal anemia in this case. Your book lists a few other tests, so the color Doppler ultrasonography, amniocentesis, chordocentesis. These are the ones they used to do before this was invented. So here's a picture of what the antibody titration looks like. And so they literally just make a tube, patient serum, and they dilute it out until it's not positive anymore. We used to do them where I worked, and we were so bad at it, we quit doing it. We just started sending them out. It's hard. It's very tedious. And so if the doctor orders one, we just send it out. So ultrasound, this color Doppler ultrasonography, it can detect fetal anemia. And so it looks for increased cardiac output and low blood viscosity. And so the severity of the anemia is determined by evaluating the peak systolic velocity in the middle cerebral artery. If anybody was wondering, I'm not gonna ask you about that. Amniocentesis, we talked about this a little bit in the body fluid part of your analysis. And so the amniotic fluid is scanned spectrophotometrically for 350 to 700 nanometers. A change in the optical density above 450 is a measurement of bilirubin. And it's the graph that they plotted on is called a Lilly graph. Have you ever heard of that? And so I'm not gonna ask you to interpret it because they usually use the color Doppler now, because we're not doing this as much as we used to, because it's invasive. So So this is what it looks like. So the alternatives, based on the amniocentesis results, the pregnancy continues to term, the baby needs an intrauterine transfusion, or they'll induce early labor. And the fetal lung maturity must be determined, so remember the LS ratio should be 2:1. And so just remember that number in case you see it on your boards. I'm not gonna ask you it, but 2:1, remember, LS ratio 2:1 for fetal lung maturity. During a chordocentesis, fetal blood is taken for H&H testing, bilirubin testing, and they can do a red blood cell genotyping on the baby. It has a low mortality rate. I don't know what the mortality rate is for amniocentesis, but I think it's higher than this. And the chordocentesis can be used for those intravascular transfusions, so the intrauterine transfusions.
So they can transfuse the baby through that
Yep, while it's
in the month.
in the mama.
Wow.
How often does that happen?
So I've never worked at, so that obviously that's probably only done at USA. I have no idea. Probably not as much as it used to be, because RhoGAM, making an anti-D was probably the main reason they did it. And since most people get RhoGAM when they're supposed to, not as much as they used to need it. But before they had it, there was no alternative. So it is a good thing. Fetal genotyping, I'm not gonna ask you about this either, but the fetal DNA can be typed using the maternal plasma during the second trimester. And so they'll do, it's called a, I forgot what we called it, but they'll take blood from the mama and send it off, and that's where they, like, the women find out what they're having really early through the blood test. That's what they're doing here. And so if they knew the fetal genotype, if the mama had an antibody and they knew that the fetus didn't have the antigen on its red cells, then they wouldn't need to monitor the mama. They would know this is the baby's genotype. So postpartum testing, the testing that's done after she has the baby. We called that RhoGAM workup in a woman that was Rh negative, if she delivered an Rh positive baby, or a weak D positive baby. So they do D testing in all infants born to D negative moms, and that includes the weak D test. And so that's the only time we did a weak D test in the lab, was on babies that were typing as Rh negative, born to Rh negative mamas. And so we're doing it to make sure we don't expose the mama to any type of Rh antigen. And so even if the baby was just weak D negative, we're still gonna give RhoGAM, just in case. So the false negative results, it can be from the D antigen sites being blocked by the mama's antibody. And in that case, you can do an elution, and the anti-D, if it's an anti-D antibody, it will show up on the eluate. False positives can happen if the weak D test is performed on red cells that are coated with antibody. And so if the DAT is positive, that's what that means. So if the DAT is positive, the weak D test can be falsely positive. And in that case, the RH control will be positive. Can you interpret the baby's RH type if the RH control is positive? No, if the RH control is positive, the test is invalid. And so you would literally result it as unable to interpret. And so however they want you to word it, it's gonna be in their policy. So if you got one, it's gonna say on your procedure, if this happens, this is what you say in the computer. If this happens, this is what you say. But you can't interpret it if the DAT is positive. I need that. So postpartum testing, you can go back and look at this chart. So the ABO testing, they only do a forward, so A, B, and D. ABO antibodies are not produced yet, so they don't show up until about 4 months old. So if you do a reversal accident, like my friend that I told you about, and it doesn't match, and then you're like, whoa, I have a really weird discrepancy, it's because those antibodies belong to the mama. Don't do a reverse on the baby. Cord blood is washed to remove Morton's jelly. So I got some jelly that I wanted to try to make a mock cord blood with and let y'all practice washing it. And so if we do that, if I can figure out how to do it, I've never done it before. We'll do that one day just for fun. In the DAT, an elution may be necessary if the DAT is positive and the mama's antibody has not been identified yet. Some places, if the DAT is positive and the mama has an antibody, they're gonna do, and they know what the antibody is, they're still gonna do an elution no matter what. So just follow what their policy says. So you need to know what tests are done for postpartum testing. So it's an ABO. It's only 3 of them. D-typing and a DAT. That's the testing that's done on the baby postpartum. And remember, they only do that on O mamas that have A or B babies and O mamas that are RH negative and have an RH positive baby. Intrauterine transfusions. So you have to be careful interpreting the ABO, RH, and the DAT in newborns that have had intrauterine transfusions. So the cord blood may phenotype as O negative because they give O negative blood for an intrauterine transfusion. And the DAT may be falsely negative or weakly positive. And so you're not gonna see one of those unless you go to like children's and women's. Nobody's going there. Prevention of HDFN, so RhoGAM prevents alloimmunization in D negative moms. So it's literally like a vaccine for the D antigen. And so D is the most immunogenic, and so that's why it's the only one that has an immunization. So antepartum administration, the initial dose, which is 300 micrograms, is given at 28 weeks. In postpartum administration, so this is while she's pregnant. This is after she has a baby. So non-immunized women, so that means if her antibody screen is negative. Within 72 hours, she gets 1 full dose. That window is important. I've seen somebody or heard about somebody that actually got discharged before they got their RhoGAM. So whether that's because they left on their own or whatever, I don't know the story. But you have to do what you can to get them to come back. They need to come back. They have to get that RhoGAM within 72 hours because once their body starts making the antibody, nothing you can do about it. So even people that have their babies at home, if they need RhoGAM, they're gonna get it somehow, hopefully. Second.
Which said the non-immunized?
So if they have a negative antibody screen, which means they have not made an anti-D. So more than 1 dose, so let me make sure y'all understand. Means negative antibody screen. so if she has been immunized, if she has an anti-D, then there's no point in giving Rogam, right? That's all that means. So more than one dose may be necessary if there was a fetal maternal hemorrhage greater than 30 mils. So one dose of Rogam, 300 microgram dose covers 30 mils of whole blood. So that's important, you do need to know that. So if the Rosette test and the KB stain, the Clyde-Howard-Betke stain, determines that there was more than 30 mil bleed, then you'll just do the calculation to see how many extra vials she needs. If her testing is negative on her Rogam workup, so the fetal cell screen, if it's negative, she still gets one vial no matter what. So screening for fetal maternal hemorrhage, that's what we call a Rogam workup. Your facility may call it something else, that's what we call it. So Rogam candidates, so everybody that's RH negative that has an RH positive baby or a weak B positive baby gets screened for fetal maternal hemorrhage. So the most common screening method is the Rosette test. It uses the postpartum maternal specimen, so the specimen from the mama after she has the baby. I have seen people try to use the baby's blood. I've seen people try to use the blood from the mama before she had the baby and grabbing the wrong tube. People do crazy stuff. And I have seen people that do not understand what they're looking for, like the whole point of doing this. And I don't know why they don't understand. But you use the mama's blood. After delivery. And so what you're looking for is the fetals, if any of the baby's blood got into the mama's blood. And so if that happens, it's usually gonna happen during delivery. So you wait until after she has the baby. Usually they'll do it the next morning with the morning rounds. They'll draw one tube of blood from the mama, a pink top, to try to see if she has any of that baby's blood in her circulation. And so it's a super easy test. And so it uses the mama's blood. They're incubated with a special anti-D. It's a little bottle. It's like half the size of the one we've been using. And then D-positive indicator cells are added, and then rosettes are observed under the microscope. And so you know the DAT that we looked at under the microscope, so we're looking for those clumps? That's exactly what it looks like under the microscope. And so you literally count them. And so rosettes are observed under the microscope. Less than 1 per 3 power fields means they get one dose. More than 1 means that the bleed needs to be quantitated. So you'll follow their procedure. I think that the kit that we used said more than 5 in 5 fields. So if you saw 1 in every field, then you did a screen. So if you see just 1, then they're just gonna get 1 vial Rogam and move on. So this screening test, super easy. The staining test is a little bit harder, the quantitative test. And so this is what you do. So you start by making a red cell suspension with the mama's blood. You always start with a suspension. You'll add this special anti-D, incubate it for 5 minutes and just sense it room temperature. Wash it, and then add these special indicator cells to it, centrifuge it, and then you can look at it under the microscope and you can pour it on a slide so that you can count to see how many rosettes you have there. And this is what it looks like when you pour it on a slide. And that, remember the DAT, that if you were to blow it up, that's what it looked like, where you have those clumps under the microscope. So quantifying the hemorrhage, so that's to calculate how many doses you need. You can do it with flow cytometry. A lot of the places that we went to that do flow cytometry, I asked them all, are y'all doing KV stains or quantitating fetal-maternal hemorrhage with flow, and they all said no. It's got to be easier than sitting down and counting 2,000 cells. There's probably a reason they're not doing it. I don't know what the reason is, but maybe one day, because the flow cytometry is a much more, it's a much better test.
More expensive?
It probably is. It probably is. So we call this a KB stain. It stands for Kleihauer-Betke. That's gotta be the people that invented it. And so the test is based on the facts that fetal hemoglobin is resistant to acid, so it keeps the stain in. Adult hemoglobin is not resistant, and so they turn into ghost cells, that's what they're called. So you need to know this for the test. And so when you look at it and you're counting, you literally make a slide and you get these 3 cups, they're called Coughlin jars. And you pour your stain, your buffer, and the other solution in the third one. And it's like giant Easter eggs, and so you'll take your slides, you have a positive control and negative control, and then you'll make a couple of slides on the mama, in case you get a bad one. And so you'll drop them in the first cup, and then you drop them in the second cup, and then you drop them in the third cup. And it's like 5 minutes on the first one, 8 minutes on the next one. It takes a long time. And then you let the slides dry all the way, and then you start counting. You get a little clicker, and you count 2,000 cells. You have a clicker in both hands. And so you count how many fetal cells. So these will just look like a shell, and these are gonna be dark pink. The fetal cells will be dark pink. And so the adult cells are the ones that look like a shell. You'll just see the outside of the membrane. And you use the number of how many fetal cells you counted in the total 2,000 to do your calculation. I always thought it was fun. It just takes a long time. So if you're busy, they're hard to do. But I like doing it. And so this is what they'll look like. I blew it up really big, but the fetal cells, there will be no mistaking them if you do your stain right. These are super bright, and these are the adult cells. And so that's what they call them, ghost cells. That's the picture from your book. And so the calculation, I'm not gonna make you do one on the test, but you count 2,000 cells times the maternal blood volume. So this is just the average maternal blood volume, it's 5,000 mils. You can do a calculation to determine her actual blood volume if you know she weighs like 600 pounds. I don't know, that's just a bad example, but you can use her, I don't know, you can use her height and weight, because she may have a higher blood volume, she probably does, and so she may need more RhoGAM, but for standard calculations, I always just use 5,000 mils or whatever my procedure says, because the procedure is gonna tell you exactly what numbers to use.
I don't guess I never really thought about it, but yeah, it makes sense that like, say I would have more blood than you.
Yes,
know.
you probably do. So that's just normal anatomy. That's why men can donate, sometimes they can donate double units when you donate red cells. Men always have a higher H&H, right? Unless you're anemic, men have a higher H&H than women. And I think it's got a lot to do with like your hormones. That makes that happen. And so you'll divide, once you get this number, you'll divide it by 30, because 30 is the number of mils that 1 gram, one dose of RhoGAM will cover. And so you divide your number that you get by 30. If the decimal point is greater than 0.5, you round up. If it's less than 0.5, you round down, and you still add 1 vial to that number either way, because this test is not very specific or sensitive. are we on? I'm on the.
10.
Oh, so we're on it. We're on 10.
Yeah.
Oh, we're done, yeah. Oh, because I gave y'all some pictures. So intrauterine transfusion is to prevent, to correct the anemia and prevent heart failure. They use group O, D negative red cells. They want fresh blood, so blood that's collected within the last 7 days, fresh blood that's gonna live as long as it can if you're going through the trouble of this invasive transfusion, right? That's the point of that. They're irradiated to prevent graft versus host disease. You need to know that for the test. So that's the whole point of irradiating anything, is to prevent graft versus host disease. And they usually use CMV negative, and obviously all blood at this point I think is leukoreduced. And then negative for hemoglobin S. Phototherapy is the initial treatment for hyperbilirubinemia. So when the babies are yellow and they send them to go under the little light. The light converts the bilirubin that allows it to be excreted in the bile. And if the patient is unresponsive, then they'll do the exchange transfusion. And there's the baby sunbathing. And cute. So exchange transfusions, they replace 1 to 2 whole blood volumes. And so they're trying to get the bilirubin down and fix the anemia until the liver can start helping clean it up. So it corrects the anemia without expanding the blood volume. So they take, I looked up a picture of it, I didn't put it on here, but it shows the baby hooked up to 2 tubes, and one's taking blood off and one's putting blood back. It removes the newborn's red cells and replaces them with antigen negative cells, so if the mama had an antibody, say she had a KEL, they would have transfused with O negative, irradiated, fresh, KEL negative cells. That's what they would have used. It reduces the bilirubin, which prevents the kernicterus, and reduces the mama's maternal antibody. So once they get all the maternal antibody out of the baby's not gonna make it anymore, it's the mama's antibody. And so that fixes it. So for exchange transfusion, the ABO and D type is determined in the infant. Maternal or infant serum or plasma can be used for the antibody screen. And if she has an antibody, they give her antigen negative blood. And so for the test, just remember that it's O negative irradiated blood. That is it. And so the last thing that I wanted to tell you, that is not a test question. So the Rogam is literally an anti-D antibody that they give to you, right? To prevent alloimmunization. So when the mama gets it at 28 weeks, I forget what the half-life of it is, but it lasts for several weeks. So by the time she delivers, that anti-D still may show up. And so it may look like she has a positive antibody screen, because it's a passive antibody, but it is in her blood, right? And so it'll look like she's made an anti-D. So all you would do at that point is look at her antibody history, her history, and see if she got Rogam. If you can prove that she did get Rogam, which it should say in her chart, she received Rogam, and it'll have the exact date. Then you can put in your comments, anti-D due to Rogam. Rogam was administered, and there's codes for all of that. You don't usually have to read next to it. And so the Rogam was administered on October 6th, 2023. Just say the 6th.
The 6th.
Yeah.
Today's the 5th.
And so when you see that first antibody screen on the lady that just had her baby, and it looks like a D, don't panic. If she got Rogam, you're gonna call it anti-D due to Rogam. And so, but she's and even though her Rogam is still showing up, it'll be weak. She's still gonna get another vial.
We always got cards. I always got a card. Every time I got Rogan, it said the date, time.
And so they probably are getting, does it have a lot number on it too, like, I don't know, probably does.
I think so.
But if the cards, I never got to see them because the patient probably has it, so the nurse is probably using that to put the comments in her chart. And so you just go look at it, hey, this is when she got Rogan, move on. So it's nice to get those, because you're like, oh crap, I have a positive antibody screen. Oh, she got Rogan, it's due to Rogan. So you still have to rule everything else out. So if you know she has Rogan, you run a panel that's D negative. All the cells on that whole panel are RH negative. That makes the D not show up. If nothing else shows up, then you've ruled everything out. You don't even have to work it up. So it's so amazing. Really nice. So you'll just run the D negative panel. If there's nothing else there, that means she doesn't really have any antibodies. You'll get experience with that. I still have people trying to work it up. Like, it's a rodeo, not reading it.